Okay, thank you, Rubul. Thank you for confirming that. Yeah. So good afternoon, everyone, and welcome to the Development Studies lecture series that we have organized here at the Department of Humanities and Social Sciences, IIT Guwahati. We are very happy to have with us Professor T. Sundararaman, and who will be speaking today on a topic titled "Lessons from India's COVID Pandemic Response." What we got right and what we need to do better. To briefly introduce Professor Sundararaman, it's a great pleasure to introduce my teacher as well as my mentor, Dr. T. Sundararaman. Presently is a global coordinator of the People's Health Movement, which is a global network that brings together grassroots health activists, civil society organizations, as well as academic institutions from around the world, and particularly from the low and middle income countries. PHM, with its varied activities and programs, is present in more than 70 countries and focuses and its work with a commitment to right to health and health care with universal and comprehensive health, primary health care as its main strategy, along with the focus on understanding the social, economic, and environmental determinants of health. Professor T. Sundaraman is also an adjunct faculty at IIT Madras, Chennai, as well as the Jawaharlal Institute of Postgraduate Medical Education Research in Pondicherry. Professor T. Sundaraman has worked closely with government and is also presently the chair of the Technical Advisory Committee of Health Technology Assessment in India, set up by Ministry of Health and Family Welfare, whose main objective is to understand the appropriateness and cost effectiveness and evaluate the various medical and health technologies introduced in our country. Prior to this, Professor Sundararaman was also the professor and dean at the School of Health Systems from 2015 to 2019. Before this, he was also a visiting faculty at the Center for Social Medicine and Community Health, Jawaharlal Nehru University, where I had the privilege to learn from Dr. Sundararaman as a doctoral student in the center. He was also a visiting scholar at the Center for Advanced Study of India at University of Pennsylvania in 2012. Professor Sundararaman has been a pioneer in working with the public health systems. And when the state of Chhattisgarh was formed in early 2000, he went to set up the state health resource center in Chhattisgarh and pioneered the Mitanin program, which has been the precursor to the Asha program under NRHM that we have in our country. So from 2007 to 14, sorry, he was also the executive director of the National Health Systems Resource Center at New Delhi, where the NHSRC provided the technical support to the number of initiatives undertaken as a part of National Rural Health Mission. Professor Sundaraman has published extensively, and we all have learned and formed our opinions and critical perspectives from the varied vast topics that he writes on from in public health and health system strengthening. And I am not going to list out the wide range of topics on which he has published extensively. I'm sure most of you have also read his number of articles that he has written over the past 1 year since the outbreak of the COVID-19 pandemic. But his latest book is published by the OUP, entitled Public Health Informatics, Designing for Change, a Developing Country Perspective, along with Professor Sandeep Sahai and Professor John Brahm. With this short introduction, sir, I welcome you here at the Department of HSS, and you can take around 45 minutes, and then we open the floor for discussion. I think um, Professor Sundaraman. Can you hear me? Just a minute.
Hi, sorry, we're having, I think, some technical. I think we've lost Professor Sundararaman for just 2 minutes. So once we get him back online, then we'll continue.
Uh,
Put,
Professor Sundaraman?
yeah, I'm back. Yeah,
Okay, okay. So you can take around 40-45 minutes or so.
yeah, sure.
Yeah. Thank you for having agreed to give this lecture.
Let's start straight off. Yeah, because this network is troubling me. My network is usually stable. I wonder whether I have to download the Teams app separately.
I think yeah, you had to download that.
Maybe I'm doing it, letting when I click it is downloading, but I should have done it separately perhaps. Anyway, let me get going on this and start by sharing this.
Okay.
And yeah, there. Are you all able to see this?
Yes. Yes,
Yeah,
Professor.
right.
Yeah.
So I will start off with this. I have some 20 slides. I want to introduce you to the topic. I'm assuming that uh, not many of you are from a background where you would have learned about this in your own teaching. And anyway, it's a new virus. Now, we are into a second wave. There should be no doubt. And we are into a vicious second wave that is faster than and more fatal than the first. But we need to learn from the first wave, and we need to learn so that we can do better. And this is a good opportunity to learn to do better. When we talk of health systems, there is one concept. There is a concept called resilience. What we mean by resilience is very apt because everything, the whole of social systems has taken a big hit with the COVID-19. But this happens, and when we build a health system, it must have the capacity to come back to respond to the crisis and maintain its core functions and reorganize if necessary. So, when we are talking of how a health systems perform, how well it performed is a measure of its resilience in a pandemic. And therefore, I introduce this term which will keep coming up for you, and therefore, it's good to know. Now, when you are talking of a components of a response, India's response, I'm not going to spend equal time on all of it, but give you a broad idea of what it covers. There are public health measures, there are medical products, there are service delivery, there are human resources, health information, finance, and governance. Let us say that human resources, information, finance, and governance is applicable to all domains. But when we are talking of public health measures, we are talking of something very specific. We are talking of what is a lockdown, what does it mean? It's a very unusual term that has become everybody's term now. Social distancing or physical distancing, test, track, quarantine or isolate, disease surveillance. These are a set of measures that relate to public health. Then you have another area which I could have put as part of service delivery because service delivery needs diagnostics, vaccine, equipment, oxygen, logistics. But I did not because we are not talking of the hospital and the doctor. We are talking of pharmaceutical company, diagnostic company, bioengineering. We are talking of manufacture, shares, trade, global politics, right? When you talk of vaccines, it's a matter of global trade, intellectual property rights, manufacturing, and those who are in that end is a different problem. And therefore, we are talking of those challenges. And then comes to service delivery, which could be of mild for primary care, it could be secondary, tertiary care, but we will largely cover the specialist skills in the hospital care. So these are the areas that we need to actually look at when you are talking of a response. Now, one thing about this India's response was that we had a lockdown. By most understandings in the world, this was most stringent, longest, widest, effectively implemented lockdowns in the world. Very few places had a lockdown so strict, so severe, so long, so wide. It was restriction of all work-related, cultural, recreational, and transport activities. Many countries had restricted some, but not all of it. Many never stopped transport. Many allowed certain forms of recreation like taking a walk, going to the beach, but we had it really strict. There were three justifications used for such a severe lockdown. The first was containment, and they defined this to mean that if you have a lockdown, you will prevent community transmission. What did they mean by community transmission? That you will not have many cases. If in community transmission, you have many cases where you don't know from whom he got it. Whereas in the early stage, you have an international traveler coming to India, he will get the disease. So you put him in quarantine and you can catch him. At best, he would have met three or four people at the airport or some people on his way home. So all those people you quarantine, and the new cases will come from within the quarantined people. Can you understand that important thing? I won't get a new case in some other. If the person has landed in Guwahati airport and gone home, I'll get only along that chain of transmission. I can't expect it to be there in some other town in Assam. That would be localized, well specified transmission. But community transmission passes that. And one of the aims which was really pushed was that we will be able to limit it to community transmission. Actually, even when the Prime Minister was announcing it, community transmission was ongoing. And if you had only on a limited chain of transmission, why lock down the whole country if you knew where it was transmitting? And finally, look at what happened. The migrant labor at that time, when you had a lockdown, only four, what was the total number of cases in India? 462. When July you let them go, what were the cases in India? So many lakh cases. Right? And in some sense, containment had miserably failed because the lockdown had been there. And actually, the disease grew within the places where the migrants were staying and spread with them. So that's really not a justifiable reason. But another reason that was used was mitigation. Of course, containment has worked in certain countries under different circumstances, but in India, it's a problem. Mitigation is called flattening the curve. Yes, you will have cases, but you don't have so many cases that your system gets flooded. It's difficult to say because we had such a huge peak as soon as the lockdown lifted. Whether mitigation succeeded, perhaps it would have been worse without it, and that has been argued by many. So the third point about it is, and this is really valid, when the disease outbreak happened in March, we really were not prepared to manage it. Our beds were not ready, our diagnostic kits were not in place, people did not have the skills, training, understanding of what was happening, and an initial lockdown could help to get time to prepare. But this brings me to another interesting question. Why not have waited till it peaked and then give a lockdown? Because the number of intermixings that you stop is much less. So there is a one argument which many countries did, like Sweden and even UK, that once the cases have increased to a certain level and hospital beds are flooding, at that time you lock down so that you reduce the cases, but after that you let go and let it come back again. But look at this chart. I don't know whether you can see it. The last three columns are stringency of the lockdown in the first quarter, that is January, February, March, then in April, May, June, then July, September, October. This is taken in October. The stringency measure is done by Oxford University. You can see that in stringency codes on all three quarters, India tops. India has the highest stringency codes. Nepal is high. Bangladesh is high. But if you see at some of the big performers at the bottom, like Australia and the Japanese, even Thailand, even Myanmar, their stringency is very low. Their stringency is very low. But their cases of million in Thailand is only 52 cases per million, whereas India has 4,897 cases per million as of October 5th. We have 75 deaths per million. Thailand has 0.8 deaths per million. So this is one strong argument that I used to say that lockdown may have an immediate effect, but even as immediate as the first 3 months. But after the first 3 months, whatever advantages it has is lost. And in the 3 months, it brings a huge social cost. This is what I am trying to say with this. The problems of the lockdown in Indian conditions were they were done with little or no preparation and little consultation. No consultation with the states, no consultation with different associations. What would have happened if everybody had been told we are going to lock down on March 30th? Today is March 20th. Please call your children home. The colleges are going to close. Please let your families come back. The migrant families come back. The construction worker is going to close. We are running extra trains. Please go back and then we are closed. What would have gone wrong? One theory was that the disease would have stopped from spreading, but you were claiming that it was only not spread, it was only on limited chain. So we could have given advance. No need to have done it like demonetization. Suddenly one night you have to announce it. The second problem is social distancing is all right for a house which have two bedroom, 3 bedroom, 2 BHK, 3 BHK house. But if the whole family is sleeping in one room and using a public toilet, where is the possibility of social distancing? And when you confine a huge working population to stay at home in the slums under such condition where every house is this, actually the interactions between people may increase rather than decrease. So the reality of Indian condition hasn't been fitted in. And finally, this was implemented like a law and order mechanism using police force enforcement rather than persuasion and health education. So that it led to huge degree of stigma and denial that we saw later, and it huge to people hiding cases, and it led to a loss of civil liberties. Then there were measures like hotspot containment, 5 kilometers around the house, we contain everybody. Not very helpful. Not very helpful. If my neighbor has got COVID-19, my chance of getting COVID-19 is not higher if I'm in an apartment block, unless I visit my neighbor's house regularly. It doesn't come floating through the air. It has to come with a maximum float of about 6 to 10 feet. And when you are directly talking with the person or around that area. So, in some sense, one of my friends, public health persons, declared it this way that lockdown is a raft that helps you float till you reach the shore. Oh, till you reach the shore. But if you do not reach it fast, you would surely die. What does it mean? It means lockdown buys you time, buys you time to put other emergency measures in place. But if you don't put it in place and if you are not ready, you cannot continue indefinitely in lockdown. Sooner or later, it will break down and you are going to be able to not reach the shore of that. This is something that we need to really look at. And when we therefore talk of resilient health systems, we need to be able to talk not only of disrupting health system, but of not disrupting social life. A health system should be so robust that when faced with the crisis, it does not upset the all of social and economic life. Now let me come to the other public health measure, mask distancing and hand hygiene. I just want to explain a principle here to all of you before I go further. How does the virus transmit? The virus goes and inhabits, colonizes the throat and nasal passages, the mucous membrane there. Like we have skin on the outside, you have on the throat and mucous passage, it goes and multiplies there. Then in some people, it will go from there, penetrate through the mucous membrane and reach the lungs, when it will cause disease. Then you get fever once it has penetrated, gone to the blood and the lungs. Then you get fever, you get headache, you get your lung breathlessness, then you get. But when you cough or you sneeze, this virus gets thrown out. maximum 6 to 10 feet. Then it drops to the ground where it doesn't stay viable for very long and it doesn't infect. Okay, may dry and become part of the dust, but when you sweep, it may rise up and you inhale, but very rare and not for very long. Suppose a person, an infected person was in a room. Then when he left the room, you closed the room. And then you opened it and went in after the next day. Will you get infected? No, you will not get infected. The virus does not live that long. If it is virus is on a dead body, will you get infected? No. It is only if a person is breathing and coughing. And as we all know, or ought to be knowing, dead bodies do not breathe. And therefore, they do not spread. Of course, if you touch with an unwashed hand, your hand on the body and some spit has fallen there very recently, again, if it is more than a few hours, it will not matter. And then you touch the dead body and then touch your own nose, it may happen. Otherwise, bury or cremate, it makes no difference. Yet there is so much fear because we do not understand it. So then when people are afraid, they say, oh, ban everything, close everything. When you say close everything, one judge has ruled yesterday that even if you are traveling alone in a car, you can spread disease. Yes, 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 you can spread. If you stop at a traffic light and you open the window and a flower seller comes and you talk to them, but the probability is very low. If you ask people to be masked at all times, at all places, you can't prevent, you cannot maintain it. People cannot do it. We are not built that way. We are social animals. We like to meet. We need to meet. We go crazy if we don't meet each other, younger people, etc. And therefore, we have to remember that many of these things, the absolute is not the benefit. What is the most probable close encounters is where you need to take care. So the present approach is a high pressure publicity and enforcement by security authorities. So the policeman, where does he enforce? He enforces it when you're riding the scooter on the street. But at that time, you can't spread much. It doesn't go from the air and go and catch somebody walking in the street. You have to be across that person for 15 minutes and talking within 6 feet for it to spread. It has to be a close encounter. Suppose you are driving in a scooter and somebody walks by and you cough. The virus load that will reach him will not be enough to cause infection. So, but they will stop you on a scooter because it's easy to stop you on a scooter. And many people will wear it when they are on a scooter. When they get down and enter the hall, they'll open it. And actually, they should do the reverse. They need not wear it with the scooter, but when they are entering the hall, they have to put it on. So, these uncritical things. So, then enforced by security agencies, strict observance in the early period, but by September, when it was peaking, it was lax. And the worst problem is everybody, when you ask them why you have a second wave, why you have a first wave, people say people are not behaving responsibly, which doesn't help. In a sense, all communicable disease is because it spread to one person to another person. Why have medical science at all? Why have public health science at all? Everything spreads from one person to another person. You have to understand that people's behavior is part of the whole issue, and we have to look at how you would address behavior change communication. There is a whole science there. You find out, for example, what would I have done, what would should the government have done or should be doing in the first wave, should have looked at, okay, in a slum, who is wearing, in apartment blocks, who is wearing, who is not wearing, meet some of the people who are wearing and say why they are wearing, and some of those who are not wearing, why they are not wearing, understand what problems different people in different society levels face. One, therefore, all of people are not homogeneous. You divide them into audience segment for the message, define the determinants of behavior, then design the message, choose what complex of message, media, and communicator. You have Amitabh Bachchan speaking on NDTV is not going to reach the message to everybody. Many people who don't watch those TV channels and are in no situation to see that. How do you actually reach it to each and it won't make a difference to them. There are other places where it won't. So you have to and then evaluate to see what works. When you have a systematic approach, you will have behavior change. If you just are talking about enforcement, discipline, then you get very little done. Now coming to the next area on medical products. The big achievement, if you ask me, the single big achievement which I am impressed by in the Indian response is what we did in testing. Truly phenomenal. So we started late. We started only March 23rd, we went to lockdown. March 22nd, only the first meeting occurs on diagnostic kits. Never mind. We got up. From 1,200 tests per day in March, we are doing 1.2 million tests per day by November. Huge. Nowadays, they say 70% RT-PCR, 30% rapid antigen. This was both. And we are doing more than that now. From 3 testing centers, we went up to 2,500 testing centers. And mind you, the production of a test kit is not only the test kit, but it is the reagent, the transport medium, the cotton swab, the equipment, training people, training laboratory attendants, all of it. Remarkable increase. In March, 95% of it was imports. Active policies of technology transfer were followed. So, how this happened is a remarkable story. But having said that, on the ground there were gaps. First, contact tracing has been very weak, one of the weakest things. Instead, people do fever survey, which is not bad, but is not a substitute for contact tracing. You must find out if somebody is positive, who all he has been in close contact with, not the fellow he passed, but somebody with whom he spent more than 15 minutes together within 6 feet without masks. Such people you should find, or were in the same room for a prolonged period of time with air circulating. Such close contact should be quarantined. Now we must understand the difference between the word quarantined and the word isolation. I wish it was a live class, then I could have asked some of you to say that. Quarantine is for people who are not tested positive, who are suspected of being a contact who will become positive. Isolation is for people who have tested positive. And that is a huge difference. It's not the same thing. Quarantine, people are reluctant to go to quarantine. You go catch somebody and say, please, you have to come to quarantine. Why? You are in that shop buying rice when another person buying rice was in that shop. That person has turned positive. Now you have to come. He said, no, I'm feeling well. I may not get the disease. Why should I quarantine? So you may in practice have to allow home quarantine, make sure he follows it. Because if 7 days later he has not developed the disease, you are fine. But if he develops symptomatic anytime between 10 and 7 days, you should test him. And on 7th day, even if he does not develop fever, you should test him. And if he is negative, you know he did not get infected. But then you would contain the infection. Right? But the person who tested positive, he should be sent to an isolation center. Now, when people are so much stigma and frank denial is there because of the way it has been approached, people don't tell you whom they have been in contact with. They'll be afraid if I tell that I was close to my mother, they will catch my mother and put her in the jail or put her in a prison or in a hospital, which may not be much better. If my child is there and they take me away, my child is in the house, who will look after my child? So you have made it non-feeling. We have made it just a law and order. Contact tracing is not a police function. It is a function of a social worker with close, good trust in the community, who has good relationships, who can negotiate with them, who can find out together as partners the best thing to do. And some place people cannot isolate a quarantine in the house because they have elderly there and they are staying in one room. And we should have community managed, community near community quarantine centers. So some things that we did badly on was this. And though our access to testing grew, it did not grow as much in weaker districts, more remote areas. And in the private sector, testing has been costed enormously high, 3,000, 4,000 rupees. No need at all. The test kit is available for 130 rupees. Even with overhead, it should not be more than 250 rupees, 200 rupees. But huge amounts of margins are there. And the real problem is the weaker the primary healthcare system, the weaker its ability to test and track. And they were bringing in Arogya Setu as some sort of miracle solution to close the gap, but it failed miserably. Everywhere you go, nobody uses it. No thing has been made of it. I have an interesting figure to see over here. The best five performing states by health sector performance by RCH are Kerala, Andhra, Maharashtra, Karnataka, Tamil Nadu. These are the good performing states. Okay, in IMR, MMR. Look at their cases per million. Kerala has 19,000 cases per million, 75 deaths per million. But its IMR is 7, its MMR is 43. Okay, whereas the India MMR is 113, its IMR is 32, Kerala is only one fourth of that. And its deaths are more or less the same, but except for Kerala, all the other high performing states, Andhra, Maharashtra, Karnataka, Tamil Nadu, have more deaths than the all India average. Their health sector performance is better, but their COVID performance is worse. But you come to the bottom and you see states like Bihar, Uttar Pradesh, Madhya Pradesh have such bad MMR and IMR, maternal mortality rate and infant mortality rate. But they seem to be doing so much better than the national average on cases and deaths. Why is this? This is because the weaker the primary healthcare system, the weaker its ability to test and track. In fact, this time Chhattisgarh has improved greatly. It's now the second leading cases. It's got 10,000 because they've got much better contact tracing going on in the second wave. And UP has also picked up, they've understood some of this. Its testing capacity has developed, and therefore you are getting more cases. So one must correlate with the testing numbers, the test positivity rates to understand the performance. Assam is somewhere down there along with this. I wasn't preparing for this. It's there. Now come to the next component. I don't want to take too much time, especially without being able to converse. It's very difficult for all of you to listen. You have the designated COVID care centers. There are three types. One is the designated COVID care center, one is the designated COVID healthcare center, and one is the designated COVID hospital. It's in government parlance, they'll say DCCC, DCHC, DCH. Now, designated COVID care centers are isolation centers. In Tamil Nadu, it's greatly successful. I haven't seen the rest, but I have heard good news from other places also. What they do is take a good college hostel and convert it into a hospital. But they admit only positive people who are not got symptoms or mild symptoms. And every day they have one health checkup. And if they are positive, if they worsen, they are shifted to a hospital. Otherwise, they are kept there, given good food, given recreation, exercise, and sent home after 10 days or less if they have been fever for more time. It's a very, very good way of bringing down the cases and mortality because many people will slip into breathlessness and hypoxia without knowing it. Here they can be watched under medical supervision. But increasingly, because there are more beds and because of other issues, government is encouraging home isolation, which is not a good idea. One must be flexible. If suppose, as I said, a child is alone at home or there is some personal problem of thing or even very afraid, you can allow some flexibility. But essentially, it is not desirable that home isolation is done, and 70%, 80% home isolation is not a good idea. Then you have moderate, it will spread. If you have home isolation, it will spread. Moderate cases, this COVID healthcare centers is neither here nor there. My understanding of them is they're not very functional, but these are actually wannabe COVID hospitals which have not established ICU beds and ventilators. So people get confused. You say there is no treatment, then why do you say we have to go and get treatment? Because oxygen makes a huge difference. and ventilation will help, and intensive care is very important, and designated COVID hospitals have the capacity to do this. But today, across the country, in the second wave and during the peak of the first wave, we were running out of. And my big problem with this is we converted a lot of major government hospitals into private hospital, into COVID-19 hospitals, but stopped treatment for all the other essential health conditions, which means people started dying of other things because the poor have nowhere else to go. So this was an acute shortage of beds made by repurposing government public hospitals, but development of skills was slow. The PMJAY government effort to provide cashless service in private hospitals is a non-starter. Very few, very unsuccessful. They would either not admit at all or admit and charge nevertheless, or cherry pick, meaning pick only those cases where they can charge fully, like if it is a sick patient and yet they know that it's not a sick patient requiring many cases of thing. I know a family of four where an elderly man and his wife 80 and 78 were there with their son and daughter. The private hospital is willing to admit the 30-year-old and 40-year-old but not provide admission to the senior people because they are afraid those people may require ventilator and then the government reimbursement is not enough for them. Whereas these people will get all right. They will just give unnecessary care and charge. So the private sector was really at all levels. In public health, of course, it never even entered. But even when it came to clinical care, specialist care, ICU care, where you said they have the highest case, it was hardly able to provide very much over there. The other important component, and now I'll go through a bit fast, is good public health logistics. In fact, part of the problem that we are having today in vaccines is logistics. You have to reach the right amount. You should not put all the vaccines in one place. They are very slow utilization, so a lot of stocks will be there. Another place they are very fast utilization, so they have a stock out. To be able to manage stocks, supply, distribution management is a huge challenge. And some states have done it very well, and some states are doing it very poorly. And it's for test kits, it's for medicine. Oxygen supply is a particular problem. Many places run out of oxygen. Some larger hospitals can build their own oxygen plant. Some can use oxygen concentrators where you don't need a supply, but many will need cylinder supplies. So the choice of what you do is an important choice. Equipment, personal prophylactic preventive equipment, the sort of dress that you need to wear to prevent health workers from getting infected, vaccines, ambulances, these are areas. The other big challenge is of sustaining all essential health services. Even your hypertension, diabetes, stroke, heart attacks, typhoid, all of them don't go away. How do you do that is the challenge on that. Then, of course, the human resources challenge, how system supports the health worker, how system cares for the health worker. The first part is how they can make their work better. So you need clear guidelines, you need to train them, you need to ensure terms of service, you need to provide protective equipment, all that is one package. But the other thing is also, and you can see this, that you must be seen to be bothered about them. Provide for sick leave, provide for breaks, don't overwork them, protection from our family. Many of them want to stay in a hostel and not go home daily because they don't want their children or elderly parents to get infected. So a nurse who has worked whole day in an intensive care unit is afraid when she goes home she will transmit the illness. So she says, "Let me stay for 1 week in this hostel or 14 days in this hostel. Next 14 days I'll work. I'll be 50 or I'll work in a non-COVID section." And then I'll come back here. But when I'm working here, I don't want to go back home. You need to build in such dimensions. The sense of a team and of public service. And they are so stressed out. They are so tired. Nobody is listening to them. So a lot of this is a major issue. Finally, governance. And there is one thing that I must really emphasize. The importance in governance, people will talk of political governance, corruption, those are another aspect. But I am trying to draw your attention to four things. One is decentralization. But the other is to build a health system as a learning adaptive system. In Kerala, you have how it learned from Nipah and earlier swine and avian flu and therefore did much better in the first round. But in fact, all the countries in the world that have done very well, Vietnam, China, South Korea, Thailand, had a SARS outbreak. And they learned to manage many of the things SARS-CoV outbreak much earlier in 2004-5. And they learned the protocol so well and they could manage it so that next time they came around, they were on top of the problem. Whereas countries that did not learn paid a terrible price on that. This is one of the big lessons of how do you build a learning system, learn and then embed that memory so that the future can use it. The second is that you just can't say, I have provided service, it will reach everybody. You need affirmative action to reach vulnerable sections. You need public information. You need integrated approaches. Then it must be a government that cares for the people, where it is seen as a right to get treated. You can't treat people as vectors of disease. They like you treat mosquitoes. Do people care when you are controlling malaria? You are bothered about people, but you are also bothered about mosquitoes. Now, the way you see person in COVID-19, are you seeing the person like a mosquito as a person who will spread disease from year to year? Oh, the migrant worker will spread. Oh, the domestic maid servant will spread. Lock her up, make her go away, let her stay at her place. What happens to her income? What happens to her rights? What happens to her rights for other care? No, you're bothered about her only as if she's a mosquito, only as if he has the capacity to spread disease, not a person, a rights bearer who has a right to be treated. That entire dimension has been something that we really need to get right in the future. Finally, financing and human resources. This chart, you may not be able to see it, shows that India is one of the lowest public health expenditures and a relatively low health infrastructure and human resource. And that in that condition, we will do poorly. Finally, a word on the vaccine. In the supply side, we have a problem because unlike in test kits, we have only two Indian suppliers. One is the Serum Institute of India, which manufactures Covid Shield, but it is under a voluntary license from AstraZeneca, which license means they have already committed to supply 92 countries through a system called COVAX, and they also have bilateral agreements. They can't export to whomsoever they choose, they can't even give. So these agreements are not transparent to us. And the Indian government struggles in. This Covishield is asking for 3,500 crores more if they have to expand their capacity. We are unable or unwilling to provide it. Bharat Biotech is an indigenous, so we don't have the patenting problem that you have and patents problem you have in Covishield. But they who produce only about 20 million doses and unable to scale up, don't have the resources for a major investment. And the option of transferring technology to many more manufacturers within India, including public sector companies, and making them work has not been explored at all. Then there are quality assurance and regulation issues which are not put in place. Okay, and the other vaccines which should have come in, what not about Sputnik, Johnson and Johnson, there are many issues. If this is one set of problems, the other is vaccine delivery. We did all right with health workers, but to the rest, the current system where you register on COVID and then they will allot you to the nearest provider, and there are many private providers who for 250 rupees will give you a vaccine, has certain advantages. It's a good system, except that it is not a good system to reach those most in need, the most vulnerable, because they do not have that sort of health seeking behavior or will even enter those corporate hospitals. So you need a good strategy to reach those who are most likely to spread, those who are most vulnerable, and you need a public health outreach strategy. For these rates, in fact, if you look at the TV programs of any of these days, now you will find the major argument going on about the vaccine delivery strategy. And you're having considerable stockouts, you're not being able to supply people and not being able to reach the people most at need. So again, we need to learn a lot about this. My last slide, I think, before I close on this. The second wave, because we are right in the middle of it, how can I not talk on this? It's larger than the first, much more rapid in rise of new cases per day and in deaths per day. In the first wave, to go from 50,000 to 1 lakh cases per day, it took 50 days, 1.5 months. But in the second wave, it has taken only 12 days. See, it's almost 3 to 4 times faster. It is not likely to be due to mutants, nor are people getting reinfected. And to say it is due to lack of physical distancing and people's irresponsibility is to say nothing. Of course, it spreads that way. But that is a helpless solution. It is to understand the nature of epidemic spreads, how it affects clusters. It may burn out for some time and then come back within another social network within the clusters. If you look at clusters as made of multiple social networks, heterogeneous clusters, then it may die down in one part and then rise up after a gap in another part. Now, if you respond to the other rise up as soon as an outbreak occurs and it is small, then you will contain it. But if many places small outbreaks occur and you have missed seeing it when they are small, they go bigger and they join together and to give a wave effect. So there are countries which have avoided the second wave, like New Zealand, or had a mild manageable second wave, like South Korea. But there are countries like Brazil, Mexico, and now India, which are in the midst of a runaway second wave. And even now, test, track, and treat remains relevant, and so does social distance. I've given a number of references of papers that we have brought out at this time. In fact, there is one paper with Daksha, which we have done together, a book chapter on this issue. But you have a number of papers in this. I've just listed on this topic in the last few months, which we have brought out on this area. So thank you for listening. And it is very difficult to talk to a screen without seeing people in front of you, but I hope I was able to communicate. Thank you.
Yeah, thank you, Sundararaman. The floor is now open for question and answers. I would request those who have questions to first raise your hands and then ask questions. You can also type your questions in the chat box. They take some time, so we'll give some 1 or 2 minutes for the students to think on for their questions.
Ask some of them to put their video on.
Yeah, they hardly
Everybody
know.
whose name does not start with A can put their name, or let us say the put your video on. Then you will get. I will also get a feedback.
So I request students and scholars to put their videos on. They hardly do so even in class. um, I had a query, sir. I just wanted to know this entire, we have this pandemic. We are in this middle of a very severe, pandemic of COVID-19, but still, there's just no push, say, apart from the People's Health Movement and the Jan Swasthya Abhiyan or the public health groups. There's no push for the strengthening of the public health agenda in our country. Like even the budget, if you the health budget of 2021, rather than just clubbing some of the allocations, there was just no increase in the budgetary allocations as well. So if you can reflect on
So,
that.
so there are two opposing trends. One, because of the pandemic, we know the importance and seriousness of public health, and we expect that public health will get more attention. But to our surprise, we find it does not get more attention, and we are seeing that even in what you were pointing out, even in civil society, even in something like Jan Swasthya Abhiyan, the first 6 months there was a high response, but now response has almost tapered off. This is a how do we understand this? Part of the understanding is that you need a very strong democratic movement to be able to enforce public services. In fact, what public services we have is won by the people and safeguarded by their action and by the democratic process. Now, because of the nature of COVID-19 response, the democratic process is all but halted, except in very like farmers' agitation, it breaks through. So people's protest, people's voices have become so muted that you are not able to force a discussion. And unfortunately, even in civil society, to be able to meet, to mix, to energize each other, all the processes of rallies, of being able to, even interact. In the absence of all that, people tend to be testy, fight with each other. There is a pathology that sets in. Meaning, it is not only that the government does not allow democratic processes or weakens democratic processes. Because of internal contradictions, democratic processes also weaken in this whole abnormal situation which is there. And in the absence of a democratic organized pressure, it is always the private sector that tends to. Therefore, the number of billionaires in India has increased in this period. The handover of public resources to private corporate has increased in this period. Privatization is being pushed in this period. When you would actually see, as I was telling you, there's a spectacular case to show that the private sector in health did not deliver and the public sector, with all its faults, did. Despite that, because of the absence of democratic processes and because of the weakening of democratic processes, it is privatization that grows, not deprivatization.
Okay, so I see two hands been raised. So I will request uh, Vikas to
Raj,
speak first, and then Rashri. Vikas.
Hi, ma'am. Hi, sir. So, I wanted to ask you a question. So you spoke about vaccination as a solution. So, I just want your comments on the whole talk around the ethics of vaccination, the concern that different civil society organizations are raising that there's a serious lack of ethics and consent around the whole vaccination process. So, if you can comment on that and what your
uh, there have been issues in the problem of approvals and trials, clinical trials. But insofar as vaccine delivery goes, um, the problem of equity is there, but the problem of ethics in the abstract sense is not so much of a issue. But equity is a big issue. Equity in access has been a big issue. In that sense, ethics is violated. But we are not really seeing the other issues as yet. They are potentially there, but we don't see those as coming up in the way of the vaccination campaign. The issues of safety are there, they are underplayed. Reporting is weak, transparency is weak. But imagine we have 7 crore people, 8 crore people vaccinated. The number of instances where such reporting gaps are few. It is not a case for not strengthening it. We must strengthen it. But the focus should be on equity, not on the fact that a few people here and there got side effects that weren't reported. But there should be the adverse effects of immunization reporting process needs to be greatly strengthened. That's one concern among many.
Okay, sir. Thank you.
Rashri?
Yeah, hi, Professor Sundar. This is Rajshri. I'm a faculty here in the HSS department. Hello.
Yes, please go ahead.
Yes, yes. So I have two very specific questions. One is I want to touch upon this whole socioeconomic costs of closure of schools and versus the community transmission issue. Where are we heading currently in the current second wave that we are experiencing? Where are we heading? Do you think? Because I mean, of course, we have lifting up of the so-called lockdowns, stringent lockdowns, and so on. But in this context, with regard to the closure of schools, this chicken and egg story of whether we should open up schools, given the community transmission that is happening, educational institutions also you could say. But mostly I'm concerned about primary schools of where children are missing out on a few years of education here. So where are we heading? I mean, what does one think of in terms of implementation of these measures? Where are we heading? That's one question I have. And the second question I have is on the issue of herd immunity. In the beginning of the COVID virus transmission process, we were hearing a lot about herd immunity. That there would be a time when where the maximum number of people get infected, and then we somewhere we are reaching a safer plane. But these days, maybe I have not heard much about herd immunity these days. So, is there something like herd immunity happening? And if it is happening, why are we seeing
Resistance to that. He said it is up to states to decide, state governments to decide, and they should do an all-party meeting and decide. He gave some gratuitous advice and washed his own hands of that. But that shifts the responsibility to the states. But what do the states do? It's difficult. But the general principle now is that we should make a strong case for we should make a strong case for lack of not restricting all movements. But we have to remember when the hospitals are getting flooded, when the hospitals get over flooded and there is a collapse condition that may take place, one would have to take the worst thing and be able to cut down activities which have the greatest propensity for transmission. Because you can't afford a hospital collapse, and sometimes you have beds, all the beds occupied and more patients still coming in, and the doctors exhausted, nurses exhausted. You will need to manage a crisis like a crisis. But beyond that, restrictions as far as possible, we have to find alternative ways rather than make across the board restrictions. But I'm not able to help with this primary school issues. A good suggestion would be to rotate the classrooms and have 2 days class on a different way. People have to come up with, instead of staying at home, close school open or school closed, you should be able to limit, rotate, and give some exposure, let the children come and go, and in a more restrained way, try to balance the necessities. It's not a good fit, but it is better than nothing till we get out of this particular mess. That I think is an important issue. But when it comes to getting out of the mess, what about herd immunity? Herd immunity is a term that represents the proportion of the population which have become immune. Herd immunity, when it reaches a certain threshold, 70%, 60%, 80%, depending upon the infectivity of the virus, then the disease stops having a epidemic potential. It stops having mass spreading. It can still spread. It can still have outbreaks, but it will not spread in a pandemic. Now, currently, zero prevalence surveys have shown herd in December, January, have shown it about 25 to 30%. Assuming that your magic number is 60 to 70% of the population, that means another 50% of the population needs to get infected. 40 to 50%. It is 400 to 500 million people. Even if we accept 1% mortality, that would mean 4 to 5 million deaths as compared to 200,000 deaths today. or a bit less than that. You simply can't afford it. You cannot have a system that plans for the acceptance of deaths at that rate. Therefore, herd immunity can never be a strategy. It is just a measure of a phenomena, a natural phenomena that people are. If you reach herd immunity, it must only be through vaccination. It should not be through natural infection. So when you reach it through vaccination, you have a thing, but you still have to vaccinate 300 to 400 million people. But you could reduce it by vaccinating those subgroups which are likely to spread more. So which comes back to your question. Why did it? I'm rephrasing your question, not asking why there is a second wave if there is no herd immunity. You are not surprised. I'm not surprised if there is no herd immunity. There is a continuing pandemic. But why was there a trough? What happened between the first wave and second wave? The
Yeah.
more interesting question is there were November, December, there were big festivals, there was a BR election, there was all sorts of nonsense happening, but yet the cases came down. Why did it come down in November is more interesting. And it came down because though there is no general herd immunity, what you have is a heterogeneous population, and in some subgroups, social network groups, within that group, a combination of level of herd immunity plus behavior patterns is able to restrict transmission. So it comes down. But since there are many non-immune clusters outside there, slowly it spreads across to non-immune clusters where it will die down. But soon many such clusters, they come together and grow up, you get a wave. So this phenomena is a major phenomena. And the way to get out of it is to have very intense surveillance in this period when there is a trough. Because the cases are few, but you want to catch them when they are few and prevent them from spreading. That's what Vietnam does. That's what New Zealand does. That's what the successful countries have done. So that is very important that we understand that particularly. The second wave is actually because we non-immune people were there. The spread, the drop in spread happened when it was going to happen. The same thing may happen again. In May, June, at one point, it will again, lot of people in the subgroups who are currently infected will get saturated. Cases will start coming down. But we would still not have reached 70% herd immunity. There will still be non-immune populations. And in those populations, fresh outbreaks can occur. Remember the great Spanish flu epidemic of 1918 did have 3 waves.
Oh.
There are countries that even now have had 4 waves already. So you must remember that as long as there are substantial non-immune populations, you would have waves.
Sir, one follow-up question I have is you said about the reinfections that the currently affected population doesn't seem like they are reinfections but new infections. So, is this based on some evidence-based study or results, or how did you
We
conclude?
don't have that good health records, but the
Hmm.
West has. In UK, in the Scandinavian country, every health encounter gets recorded. So there is a recent Lancet study that shows that out of 100 people that get infected, not more than one will develop an infection subsequently. And most of that one will be people with some immunocompromise of some reason or a proper lack of diagnosis then or now. One of those issues will be there. But reinfection is exceptional. In medicine, it's difficult to say never, but it's exceptional. So rare that on a demographic basis, as a public health strategy, we need not worry about.
Okay.
So far, we don't yet know a new mutant strains, but so far with existing mutants also, we don't have a reinfection scare yet.
Okay. Thank you.
Um, there is one question from YouTube Live. The question is asked by Rahul. He says, "Sir, do you think we need to abolish Epidemic Disease Act as it puts strains on center and state relationships in their joint efforts to respond to COVID-19?"
It's an interesting one. My question is, what is the sort of act we need It's not only the Epidemic Act that is an issue, it is the National Disaster Management Act also that is a part of the issue, where the entire powers are passed on to General Administration and the Home Ministry. And they have overreach over the states. They can actually order all the state governments, all the particular thing can be actually bypassed within that order. Uh, it's I wouldn't rush to say yes, but I would say that we need to set up far more consultative processes into the Act also, and to still use the state as the unit of planning rather than the center. This penchant of the current center to have dramatic moves, which they do all over the country, suddenly overnight, should get curtailed as it has yesterday, and we allow states to have. If we had, instead of going for a countrywide lockdown, we had lockdown in Maharashtra and Delhi and Chennai in March, we would have gone to lockdown in the other places by April, May, June, July, and people would have been in a much better situation to cope. And people would be coming out of the lockdown at different periods. So I think statewide planning is important, but it is not only in the act, it is in the practice. But the act should certainly allow a greater degree of consultation and some restraint on unchecked use.
Started doing mathematical modeling and they were trying to predict. And that went on for quite some time. We saw it for roughly 8 months. People were trying to show various kinds of results. I wanted to know your opinion about that particular thing, this particular thing.
Well, I've been always a skeptic on modeling. Modeling is very, very dependent upon two things. It is very, very dependent upon the database on which you are modeling. And we had no Indian database, especially on the social intermixture patterns. And modeling is very, very dependent upon the assumptions. And we were dealing with a new virus where all the assumptions were as yet very tentative. So I'm not surprised that it went wrong, but I'm surprised at the overwhelming confidence in which it drove the lockdown at one point or lulled us into complacency in the second wave. A DST model, supermodel, they called it, predicted, and now they start naming themselves supermodels also. And supermodel predicted that we would be see the last of the epidemic by February. And at some point I was saying the reverse. I wasn't saying it in modeling. I was saying, look at all the countries. Even good countries are having a second wave. So that's not a model. That's a guess, but it's an estimated guess that is looking at new data. I can't blame them because when they were saying it in January, December, the fact that the second wave is so universal wasn't so clear. But now it is very clear. So the assumptions are a problem really. Finally, there is a modeling problem in it, shall I say. This is something called the small world problem or something like that within the science of modeling. These are non-random variables. If there is a homogeneous mixing of populations and virus, then the scales at which you predict go along certain patterns. Very great heterogeneity in way people behave, in nature of social interactions that they have, in the access to healthcare, in the ability to follow social distancing, and in cultural practices of mixing. Some people go in Italy, I always attribute it, if you go to Italy, as soon as they meet each other, they do hug each other and give a mua, but you won't see that in India so easily. So these are cultural practices. Now, depending upon that, you can't quite predict which cluster to which cluster you go, but the population is heterogeneous. So in a subgroup, it can burn out. But when it will transmit is in a complete non-random way and therefore defeats most models. And I suppose you can still model something out of it, but one needs much greater caution than has been shown. I'm particularly annoyed with one guy called Thomas Pouille, who in the first stage made some outrageous predictions that were to lead a stampede country after country into lockdown. He changed his entire predictions within 3 weeks, but by which time most of the countries were in lockdown. So it didn't help. He changed his whole story, but it didn't help. We must understand, we must look at models and talk about it, but I don't think we need to be carried away with it.
Yeah. Yeah. Thank you. Thank you very much.
Yeah, there is. I'll just read out. There's a question typed by Alakriti. Alakriti is our doctoral scholar here at the department. Just a minute. I'm just not able. So she says, "Thank you so much, sir, for the insightful speech." Just a minute. I'm not able to see the chat. This is Alakriti, PhD student in the department of HSS. Sir,
So,
I
Alakriti, why
wanted
don't
to.
you ask her to put on her video, otherwise
Yes,
it
I
will be
asked. Actually, she just told me that their computer in the lab doesn't have a camera. So I also didn't have that idea.
okay.
So she is saying, sir, I just wanted to ask that now in public domain, the discourse seems to be very much vaccine centric. And as you mentioned, due to the weakening of democratic systems and movements are also weakened. What could be done in this case to revive the public health system? Why even the second wave of COVID-19 crisis cannot be the opportunity to strengthen our public health systems?
So, actually, this is a very, very interesting question, and I'm going to give you a far more specific answer than you may have expected. Uh, One thing remember, suppose I vaccinate the entire good 400 million just tomorrow. For the second dose of vaccine to be given and for the immunity to kick in, if I immunize 400 million people tomorrow, it will still take July first week before you are immune. Hopefully, the second wave will subside long before then. So, it's a very perverse way of saying it, but what the simple statement is, this round of vaccination is not going to help with this wave of the pandemic, or will help minimally with this wave of the pandemic. This wave of the pandemic will still have to be controlled by non-vaccine measures, with vaccine playing a minor supplementary role. But hopefully, for the third wave of pandemic, we will be there and avert the third wave. That's the best we can hope for. And even that is a very difficult story. Come to the second part of your question. Where can we make a difference? Remember, though in India 30 contacts per case will be so many million and it is very difficult. A cluster is a very finite, anything is a cluster. Your apartment blocks is a cluster. IIT Guwahati is a cluster. Guwahati is a cluster. Assam is a cluster. It's a very flexible definition. Now, it makes a lot of sense for public groups to take over a major function in contact tracing and supporting quarantine and encouraging isolation. There's a very good public health training on that. But you can and you do need, the government does need volunteers, trade volunteers interacting with voluntary groups in each area. Areas as small as an apartment block or a residential, some nagar, Bhagat Singh Nagar or something like that. In that particular area, you have a resident area committee, a welfare committee, which will cooperate with the government. We'll need a trained person there, but we'll cooperate with that trained person to ensure that people are confident and well supported and collaborate, and there is no denial and there is cooperation. That would really help. But it would also help to see that places like quarantine and isolation centers have community role in management, that there are facilitation done and people have a right to care. So if a sick person arrives at a hospital, if the hospital does not have bed, it becomes the responsibility of the hospital to transport him to wherever there is a bed. And there should be a network, never mind a network for COVID and this, wherein they can identify which is the nearest hospital with a bed having an ICU and transport the patient there. That should be the hospital government responsibility and not the individual. So individual just reaches out to the nearest hospital and the system picks him up from there if they are sick. So those sort of things are things that even now we should do in a big way. And I think the movements need to engage with this on these sort of issues wherever they are.
Okay, thank you, sir. Are there any other questions?
Yeah, maybe we should break that. I don't want to over too long.
Okay, okay then. If there are, I don't see any other questions neither in the YouTube nor in the Teams. So I take this opportunity to thank you, Professor Sundararaman, for joining us for today's talk. And I also thank Rubul, the technical assistant in our department, to facilitate this online lecture, and also Vikas, who helped us with the poster, and my colleague Dr. Vasundhara and Professor Sukanya. And thank you all for joining today's lecture. Yeah, thank you, Professor Sundaram. We will keep in touch with you. Yeah, thank you. Bye.